Okay guys, good morning. Thank you very much for inviting me to come and talk to you today. My name is Mark Dixon. I am the National Research Paramedic for East Midlands Ambulance Service. And I could talk to you for hours about research, but today I'm going to talk to you about a trial to test a pre-hospital intervention for stroke care. You'll be aware that at the moment we can't do anything for stroke other than recognise it early and drive those patients to hyperacute stroke centres. Okay, so actually trying to source an intervention for stroke would be, for paramedics to undertake, would be an amazing thing for that category of patients. So, all right, so I'm a bit of a whistle-stop tour. So for the next, well, it's about 40 minutes now, so I've got to really try and cram this down. For the next 40 minutes, I'm going to talk to you about actually what is stroke and how we identify stroke in the pre-hospital setting, what we can currently do for stroke, how we measure our performance of stroke assessment, and then I'm going to introduce a molecule called nitric oxide to you, which is given by ambulance staff in the form of GTN for acute coronary syndromes and pulmonary edema, but actually it may well have an application in stroke care. So I'm going to introduce this molecule, and that's what we're going to be testing in this trial. So the trial is called RIGHT-2, and it stands for the Rapid Intervention with Glycerol Trinitrate in Hypertensive Stroke, and it's trial number 2. So this follows on from a pilot study that was done a few years ago. I don't know, what stage of your course are you? Are you first years, second years? Second years, okay, good. So, and have you had practice placement experience and things like that? Good. So what I'm going to talk about should be quite familiar to you. So I'm going to talk about the RIGHT-2 study design, and then lastly I'm going to talk to you about where we are and some of the problems that we've had in actually launching this trial. Okay, so I'm going to pose a question to you, and my question is, what is so urgent about stroke? Okay, so you'll know that in the current research, trauma care has had a lot of attention with the emergence of trauma care centres and innovations for trauma. So you've got the cap tourniquets, the different types of dressings that we've now got, the tranexamic acid for trauma, the pelvic splints, and actually recognising those trauma patients and getting them to hospital. Myocardial infarction and STEMI care, right, so what can we do? We can give oxygen, we can give aspirin, we can give GTN, we can cannulate, we can give morphine, we can recognise the symptoms on the ECG and convey those patients to a hyperacute centre. So there's lots of things to do, lots of sexy things to do for trauma, lots of sexy things to do for STEMI care. For stroke, it doesn't have that recognition, okay, because we can't do anything. So the brain accounts for approximately 20% of the body's energy consumption, yet it's only about 2% of the body's mass. Okay, so huge energy consumption for such a small and tiny percentage of the body's mass. Now, as we know, cerebral tissue, neurological tissue, cannot store its own nutrients. So glucose, oxygen, all the molecules that we need, glycogen, glucose, glucagon, all those kind of things, cannot be stored within neurological tissue. So everything has to be provided to it. Now, the key thing about the brain that's different from those patients that would experience trauma or STEMI is that any kind of insult to your neurological tissue could permanently cause quite devastating disability or even death. Okay? So if you have an injury to your arm that's deemed as trauma, so a stab wound to your arm, actually you are still who you are, okay? You know, okay, you know who you are, you know how to converse, you know how to put sentences together. With stroke, any change to the neurological tissue, you could lose the ability to move your right side. You could lose the ability to talk, okay, based on the area of brain that loses its perfusion. Okay, so while we don't have any of these massive, sexy interventions, actually, this is pretty bad. Okay. All right, so what is so urgent? Well, any interruptions to that blood supply, supplying the oxygen, the nutrients, the glucose, the things that we need to generate that ATP, shudder and talk about Krebs cycle and things. Any interruption to that blood supply will mean that those cells die. And once those cells die, that's it. They lose their function. So stroke is the third commonest cause of death and disability, yet we can't actually do anything about it. Okay, so I'm just going to briefly talk through the different types of stroke. You should all be aware of this, I hope. So we've got ischemic stroke. So ischemic stroke counts for about 85% of all strokes that are suffered. Now, an ischemic stroke is where there is an occlusion in one of your cerebral arteries. Okay? Anything that is distal to that occlusion loses its perfusion and becomes ischemic, hypoxic, and dies. Okay, so you can see, as indicated by the black area in that left picture. Okay. The other type of stroke that we commonly see is hemorrhagic stroke, accounting for about 20 to 25% of all strokes, and this is where a vessel, cerebral vessel, ruptures, and again that tissue that is distal to that ruptured point loses its perfusion and ends up becoming hypoxic, ischemic, and dies. Okay. The main risk factor for stroke is hypertension. 70% of people that have a stroke are already known to be hypertensive. So if you can see where I'm trying to go with GTN here, link those two together, you'll see that actually if we can start to reduce blood pressure earlier using nitrates, then perhaps we can actually have a potential benefit for our stroke patients. Okay. So what is so urgent about stroke? Well, this is one of my favourite slides, which really illustrates what we can do for stroke if we can prove this intervention works. So you can see the picture of the brain, and in the middle there you have the ischemic core. So this is distal to the occlusion, distal to the thrombus. Those cells have died. Okay, nothing can retrieve those cells. So that if that's in the left part of your brain, and that's your speech area, you've now lost the ability to form words and to converse. Okay. Now, what's interesting is the light pink area that surrounds that ischemic core. That is called the ischemic penumbra. Okay. Now, the cells that are within that ischemic penumbra are hypoxic. Okay, so they are starved of oxygen, yet they still have their structural and functional integrity. Okay. So this area, whilst it's struggling, actually if we can intervene earlier, we have the potential to salvage cells within that ischemic penumbra which would otherwise die. Okay. So I'm talking about damage limitation here. So these CT scans on the right-hand side, you can see the left image, which is a diffusion CT scan. That yellow portion there shows you the area of tissue that is dead. Okay? Nothing we can do about it. The red scan in the middle is a perfusion CT. So as cardiologists would do with angiography, they inject a dye, and you can see the cells that are hypoxic. Okay? That red area is the ischemic penumbra. Okay? So if we do nothing, the red area will also die. Okay? The right CT scan there shows you the mismatch and actually the amount of tissue that we could potentially salvage if we can develop an early enough intervention. In hospitals had a lot of press and a lot of work has been done around thrombolysis. So, you know, alteplase can be given as a thrombolytic drug to break down that clot. More recently, there is work being done to test out whether tranexamic acid could be used for hemorrhage. Okay? But actually, if we can find an intervention that works earlier, then we could potentially salvage more of that ischemic penumbra. And this is where the time is brain concept has arisen from. Actually, it's just as urgent as getting your trauma patient to the trauma centre. It's just as urgent as getting your STEMI patients to the angioplasty table, okay, your PPCI centre. So stroke, although we can't do anything about it, actually has the same priority, and that is quite misunderstood across many ambulance services. Okay, so what can we do currently for stroke? Well, nothing, okay, other than increase public awareness about stroke symptoms. So you've all seen the FAST test, you're all cognizant of using the FAST test, okay, your face, arm, speech, and now time has been added in into the FAST. Now, this scale on the left here is your National Clinical Performance Indicator for stroke. So if you write stroke on your PRF, you'll be audited to make sure you've done a FAST test. You'll be audited to make sure you've done a BP, you've done a BM, and you've recorded the onset time, and you've taken them to the most appropriate centre. All of this is done retrospectively. So when you submit your PRFs into however you put them in the box in the station, they will get audited retrospectively. Okay? So there's nothing that we can currently do. So we use the FAST score. There have been other scores that have been tested. So for example, the Rosier score, which is the recognition of stroke in the emergency room. Okay? And this was tested by London Ambulance Service in 2013. But actually, it's quite a complicated scale. If you've got this, if you've got an urgent stroke patient in front of you, to go through all of these things is a little bit more cumbersome than working through the FAST test. And actually, it's got all the FAST elements in it. So it's got the asymmetrical facial weakness, the asymmetrical arm weakness, it adds in legs, and then you've got speech disturbance as well. The paper that was published on this actually showed there was probably almost identical sensitivity, and if not FAST, was somewhat more sensitive, okay? And that's what we're looking for. So we're not actually using this. There are other scales. There's the Los Angeles pre-hospital stroke scale, you've got the Cincinnati pre-hospital stroke scale, and you've got the Melbourne ambulance stroke scale, okay? So there's 3 others that are used, but currently FAST has been shown to be the best one and most appropriate for the pre-hospital setting. Okay, I'm going to introduce you to a new scale now, and this scale is more relevant for stroke clinical trials, okay? Now, we won't be using this in the pre-hospital setting, but any stroke research, you will, and you are admitted to hospital or you attend a hyperacute stroke unit, the severity of your stroke will be graded by the modified Rankin scale, and it's a 0 to 6 scale, where 0 you have no symptoms, no residual symptoms following your stroke, all the way down to 6 when you're dead. Okay? So probably want to avoid the sort of 6 area. Okay? Any intervention that is trialled in stroke, we are looking to reduce the modified Rankin score. We want to shift the patients that are in 4, 5 and 6 up to 0, 1, 2 and 3. Okay, because we'd much rather than have no significant disability than actually require constant nursing care and attention, bedridden and incontinent. So this is the scale that we use. It's used right at the hyperacute setting, so when you arrive, patients will get an MRS score, and most commonly at 90 days after a stroke intervention, their MRS will be reassessed to see actually has that changed. Okay. All right, now I'm going to introduce you to nitric oxide, okay? We're going to talk a little bit more about nitric oxide. So we're going to be testing this given in the form of a GTN patch. Now, nitric oxide is present in our cells anyway. We produce it normally, okay? Helps us maintain homeostasis. It helps us maintain that constant perfusion, okay, to the brain cells, to our body cells, okay? Now, in the nervous system, it has 2 main effects, okay? Those of you that have just had a nice big breakfast, okay, your stomach will have expanded and stretched to accommodate the food that you've eaten. It's nitric oxide that triggers that stretch. If you're desperate for a wee and your bladder is full, it's nitric oxide that has triggered your bladder to stretch. Okay, so it has some really important effects. It helps in the neurotransmission more centrally. Okay, and it helps you regulate your temperature, so your thermal regulation system is all controlled or as part of the homeostasis pathway of maintaining your temperature. Okay. All right. So some of the actions that we are looking at in this trial, now I appreciate this is quite complex, I'm not going into it, I just want to really illustrate to you the points on the right hand side. So we give GTN for its vasodilatory properties, okay? So it vasodilates, it increases the blood supply to the areas that require it. So for example in angina, it will increase the blood supply and the oxygenation whilst reducing that pressure, okay? Now, interestingly, nitric oxide suppresses platelet aggregation. So if you think you've got a thrombus, okay, in one of your cerebral arteries that has ruptured, and actually we're forming that plaque over it, that scab over it in the vessel, actually suppressing platelet aggregation is going to be quite useful, right? The other one that I really wanted to, there's two more that I want to pick out of there, is promotes angiogenesis. So angiogenesis is the creation of new blood vessels. So angio is anything to do with blood vessels, and genesis is the building of new blood vessels, okay? So if we've got an area of tissue that is hypoxic, so we're back to the ischemic penumbra, if we can try and restore that circulation by building collateral circulation, promoting angiogenesis, actually we can reduce the level of hypoxia and ischemia, okay? The other one I just want to point out to you is the promotion of glucose regulation and insulin sensitivity. So cells that are screaming out for energy, cells that are screaming out for glucose, actually nitric oxide will help balance that regulation, okay? So where cells have died, where cells are hypoxic and ischemic, where nitric oxide cannot be produced normally, actually we might be able to replace that, okay, to restore the nutrients and the insulin and the things those cells need in order to regain their function, okay? Brilliant. Now, in this trial, we are looking at the action of nitric oxide for 7 reasons, okay? So the first one, we want to try and replace nitric oxide, okay, that's going to be lost from tissue that has that is compromised, okay? We already know that nitric oxide is a vasodilator, okay? So that is going to increase the amount of oxygen, the perfusion that is necessary to those cells that are ischemic, okay? What other things we're looking for? So we're also looking to see whether nitric oxide will have its neuroprotective quality. So by doing all of these things, so the anti-inflammatory, antioxidant, promotes glucose regulation, insulin sensitivity, they're all neuroprotective qualities. So we're testing that, okay? We're looking at whether nitric oxide will increase the surface area by vasodilating the artery, increase the surface area of the clot to enable your thrombolytic drug to actually act on a larger surface area and therefore break down that clot quicker. Okay? In order to go for thrombolysis, in order to receive thrombolysis, patients need to have a blood pressure of less than 185 millimeters of mercury. How many of you patients have you been to where they're grossly hypertensive, so up near that region and above, sort of in the 200 systolic region, okay? So when your patient arrives at hospital, the first thing they're going to do is try and drop that blood pressure to be able then to start the thrombolysis pathway. If we can do that by giving a GTN patch, reducing that blood pressure, actually they can access thrombolysis quicker. Now thrombolysis has a time window of 4.5 hours after symptom onset. So if we can speed up the time to treatment, then actually we could potentially save some of that penumbra. So we're also going to be looking at the other types of arteries that nitric oxide works on. So you've got a layer of arteries in your pia-mater called your peel arteries. Okay, if we can vasodilate those arteries, we can restore the perfusion from the outside inwards. Okay, so increase the amount of oxygen and nutrients available from the peripheries in towards the centre of the brain. Okay, so there's lots of different things that we are testing nitric oxide. Okay. So, nitric oxide has been used in clinical trials. Now, I'm going to talk about a couple of these. So, RIGHT was our pilot study, so the rapid intervention with glycerol trinitrate in hypertensive stroke, trial number 1, and that was a pre-hospital trial. It's been used in hospital for quite a while, okay? It's been used in hospital for quite a while, mainly the EMAS trial, and that was the efficacy of nitric oxide in stroke. So you'd arrive with your stroke patient, and they would apply a GTN patch, and they would keep that patch applied for 7 days, okay? Just to see the effect it had, all right? Actually, overall, the EMAS trial had no real positive effect. It was a neutral trial. So patients, there was no improvement in MRS noted across the whole duration of the trial. Okay? And that was 4,011 patients. All right? However, the only significant aspect from that trial, so we broke down the patient groups, the only significant aspect was the time to randomization at less than 6 hours. So when patients in hospital received a GTN patch at less than 6 hours from their disease and their symptom onset, actually, they did better. The MRS score improved. Well, that's what we want. So by giving nitrates earlier, can we potentially make a difference? Well, yes, potentially. We need more evidence to back it up. Who sees patients at the pinnacle of disease onset? Well, it's going to be pre-hospital staff. It's going to be paramedics. So what they did, what the investigators did, was move the trial forwards into the pre-hospital setting. This graph is just a summary, okay, and it shows you how the MRS improved. So as I mentioned, GTN was given for 7 days, had no effect, but the only time it reduced the MRS was when it was given at less than 7 hours. So you can see where this intervention has the potential to work. Okay. Now this is some of the data extrapolated from the trial, and this includes the data from the RIGHT trial, but I thought this was really interesting just to illustrate to you, in the pre-hospital setting, we can't determine whether the stroke is ischemic or hemorrhagic. Okay? We have no ability to do CT scans yet in the pre-hospital setting, okay? So to you, a stroke patient is a stroke patient. Whether it's ischemic or hemorrhagic, they'll still present as similar. There will be subtle differences. Hemorrhagic strokes will have a higher blood pressure, probably increase in nausea. You probably start to notice other signs and symptoms, okay? This is the results from the trial looking at ischemic stroke patients who received GTN within 6 hours. The top graph shows you the group that received GTN. The bottom graph shows you the groups that didn't receive GTN. And the increase in shading is the modified Rankin score. So the white on the left is a score of 0, and it increases in severity up until the end. The black is a score of 6, which is dead. Okay? And you can see that for ischemic patients, we have at the end of the trial, we had more patients that fall within the 0, 1, 2, and 3 group, which is what we want. Now you're going to say to me, right, okay, hemorrhage patients, right? So we're going to vasodilate. Okay, so we're going to vasodilate a ruptured artery. And you're going to tell me that has a potential benefit. Well, aren't you going to increase the amount of hemorrhage into the brain? But don't forget that GTN works on your whole systemic vascular system. So you're not only vasodilating your cerebral arteries, you're vasodilating your peripheral arteries, okay? So you're vasodilating your femoral arteries, everything. So if you dilate the whole system, you're going to reduce the pressure in the whole system, which in turn takes the pressure off the brain and reduces the blood loss into your cerebral tissue, okay? It's like bleeding your radiators at home. You know, when you get air in your radiators, you have to get the little key out. It's usually a blue job, you know, it's usually a dad job. Get your key out, bleed the radiator, let the air out, reduces the pressure in the whole system. That's exactly what it does for hemorrhagic stroke. And actually, 30% fewer patients died who received GTN than who didn't. Okay, so a massive impact, or massive potential impact for hemorrhagic patients as well. All right, okay, so I'll just skip past that one. So I'm going to just talk a little bit about the pilot study because this has led to where we are today. So as I said, I work in East Midlands Ambulance Service in and around Nottingham, and we trialled the intervention of allowing paramedics to apply a GTN patch. Bear in mind the patch is used rather than a spray because it's longer lasting. Okay, with a spray it has a very short half-life, so it will drop the blood pressure and then it's likely to wear off and climb back up again. For a stroke patient, you don't want to have a yo-yoing blood pressure. So we apply a patch, a nice slow release patch to drop that blood pressure and keep it low. Okay. So we tried to recruit, we were after 80 patients who presented to paramedics at less than 4 hours of symptom onset, who were failing 2 or more aspects of the FAST test and with a normotensive or hypertensive blood pressure. Paramedics gained consent to be enrolled into the trial, okay, and we conveyed them to Nottingham City Hospital, which is our local stroke centre. So paramedics were either applying a GTN patch or a non-medicated unmedicated plaster, okay, to really test the difference, all right? So we need to do that randomised test to test the difference. And our main outcome was looking at the modified Rankin scale. At 90 days, we wanted to see whether the intervention shifted the modified Rankin score. 66% of our patients were ischemic, okay? 7% were TIA, and of course we had to allow for some mimics, so your migraine patients that present with hemiparesis, your post-ictal patients after a seizure, okay, we had to allow for some of that, and 12% of patients were non-stroke, all right. The results, so again, a very similar chart, okay, so the top group who received GTN, the bottom group who didn't, and actually you can see there was a potential 20% reduction in death, and a greater number of patients fell within the modified Rankin score of 0, 1, 2 and 3. Okay, you think, well, actually, that's really good, but on a really small scale, okay, we can't, you know, we can't apply that as a generalised sort of rule, okay? We need to test it wider. That was just localised to Nottingham. And actually, the median time to treatment from symptom onset to ambulance arriving to be randomised into the trial to applying the patch was 55 minutes, okay? Which is a really good achievement if you think about the time is brain concept, actually trying to restore that circulation, trying to restore the circulation to the ischemic penumbra. Okay, so that's led us on to where we are now, right to. So this is a larger scale UK-wide trial. We have 7 ambulance services involved at the moment, and we're looking for 850 patients this time who present as FAST positive, failing 2 or more aspects of the FAST score. We're asking for 2 or more aspects because we want to reduce the number of mimics that are enrolled into the trial. And we're looking for patients to have a blood pressure of over 120 systolic. If the benefits are to be believed from the pilot data and the in-hospital data, actually, we know how to manage hypotension. If it's going to drop the blood pressure by a lot, we just manage the hypertension, okay? Raise the legs, make them administer some fluids if needs be, okay? But the potential benefits, we need to test if the benefits outweigh the hypertension, okay? So we currently have, so we set out to achieve 30 hospitals. We've actually got 45 on board across the country, okay? And we're expecting around 60% of patients to be ischemic, 20% to be about hemorrhage, and then we'll allow for the TIA patients who resolve and those that are mimics that we cannot distinguish, right? And we're given a GTN patch versus a sham patch, and as before, we're looking for that shift in modified Rankin score at 90 days after their stroke. Okay, so paramedics are out there recruiting patients now across East Midlands Ambulance Service, South Western Ambulance Service, Yorkshire Ambulance Service and East of England, okay? And so the R stands for randomisation, so, and patients will either be randomised into the GTN group or the no GTN group, and the patch will be applied for 4 days, okay? And then we will follow them up at day 90, okay? The main phase of the trial is going to be running until November 2017 to try and build our cohort of 850. Okay, so these are the trusts that are taking part. Now, we have had discussions with South Central, however, because you've just recently launched the Paramedic 2 trial, which is a whole trust-wide trial. At the moment, they're concentrating on that, so won't be taking part in Right 2 for the foreseeable future. However, we're never going to say no. Just keep chipping away. Okay, so each ambulance service has a PI, a principal investigator, and then paramedics will champion it and locally lead the trial, because paramedics are now involved in research, cognizant with research, and actually becoming more and more involved in this kind of trial, which is brilliant. Before, none of this kind of thing happened. These are the stations that are going to be taking part. We've got 323 stations taking part, all in all across the country, and we're staggering the setup area by area. It takes a little while to get, for the hospitals to get their permission. So the training. So because it is a clinical trial that is involving a drug, okay, so a GTN, we have to adhere to the principles of good clinical practice. That's the NHS research training. So we have to train paramedics how to do research and abide by good ethical standards. Okay? And we do that by an online video that's smartphone friendly, so you can watch it in your cab when you're waiting to hand over at hospital, or on standby, or on station. Okay? And patients can be enrolled when they have capacity to give consent. So they'll have fast positive symptoms, but they still will understand the trial. Okay? However, if they don't have capacity, relatives can give consent, and then also proxy consent can be given should you need to. We've spoken about the inclusion-exclusion criteria. So, patients that are fast positive, failing 2 or more, with a blood pressure over 120, okay, and you have undertaken the right to training. Now, a BM of less than 2.5 can be corrected, and if those patients are symptomatic, can still be enrolled in the trial. Okay? As with GTN, there are other exclusion criteria that you would be familiar with in giving GTN normally. Okay, so these are the treatment packs. Inside the treatment packs, you've got the drugs that are in the drugs on trial in the box. And there's a wristband for your patient, and then of course you've got all of your consenting paperwork and all of your data gathering forms for the pre-hospital setting. This box, once it's opened, is allocated to the patient, and that box stays with that patient for the 4 days worth of treatment. Okay, as I said, we're testing the GTN patch versus a sham patch. Okay, and all 4 of those patches will be in the box, so it's really important to sign those packs out. So, this is the form that paramedics will be filling in. All of the data can be gathered from the PRF, so it looks like a complex form, but it really isn't. And this will enable us to really gather the onset time, the blood pressure both pre and post patch, to help us gauge how effective this intervention is going to be. So as I mentioned, our main outcome is the modified Rankin score, so that's 0 to 6 scale. Okay? And we're asking for a second scan to be done on day 2, really to see how that ischemic penumbra has changed, and whether we've been able to salvage some of that by giving GTN earlier on in the disease process. Okay? All right. So the 999 call comes in, you arrive, you diagnose a stroke or a TIA, you check that they meet the inclusion-exclusion criteria. You consent them into the trial, explain the trial, ask if they want to take part, sign the consent form, apply the patch, fill in your information, and pre-alert as you would normally. Okay? All right. So we have 26 patients recruited so far. Now, we've been live since October. However, we've had a number of problems, a number of limitations, because pre-hospital research is quite new. We have had a number of problems in getting going. So, getting paramedics to volunteer to take part is not a compulsory trial. So, generating interest in research and actually making a potential difference to patients is why you all joined the service. Okay? It's why you all joined, why you're all sat here. Paramedics are not yet prescribing clinicians. Okay? So, but yet we're asking for 3 further days of medication to be given to that patient that's been enrolled into the trial. Okay? So we had to have negotiation with the ambulance service pharmacy departments in order to try and work around how we're going to get around the supply issue for 3 further days. Okay? So that took a number of times. In order for Ambulance Trust to take part in a trial, it has to have research approval. Okay? and then to be able to recruit a patient and take to a hospital that's taking part in the trial, the hospital has to have approval as well. Now, in each ambulance service, we've got about 9 hospitals. So we need to have 10 forms of R&D approval before we can actually begin to recruit patients. Otherwise, we'll have patients that you enroll into a trial that could end up anywhere, that could end up in a non-participating hospital, and we don't want that, because actually that's one of our 850 patients that we potentially can't follow up because we can't apply the next patches, we can't trace that data. Okay? So that has taken quite a time to get sorted. So recruitment hours, we work 24/7. Okay? We run a 24/7 service. A lot of the hospital research departments don't. Okay? So we've had to devise procedures and put in place options for patients to be enrolled across a 24/7 period and still be able to be followed up. And working with each hospital in turn, that's taken a little bit of time. Okay? And then, of course, is the tasking of the Right to clinician. So if you've done your Right to training, you're on shift. Okay? You're on shift. The stroke call comes in, but you're not the nearest vehicle, and another crew goes. Okay? It's all done by response time. Okay? So tasking the Right to clinician to the stroke call is a challenge. Okay? Which is why we need as many paramedics as possible to sign up. Okay? It all counts towards your HCPC CPD portfolio. Okay? And it all counts towards your evidence to take part in a research study. Okay, so we've got some more trusts that we're bringing on board, okay, more hospitals within each of the active trusts at the moment to start up. So we've got the Welsh Ambulance Service, West Midlands, South East Coast and Scotland, who are also joining us in the coming months. Okay, if you want any more information on the trial, please feel free to visit our website or keep up to date with us on Twitter. Okay, we've just, today, Colchester Hospital within East of England has opened up to receive patients, so the blue treatment packs are being signed out from today onwards for that area. Okay, so I hope I've just given you a bit of an insight into actually how pre-hospital research into stroke care can happen and the potential benefits that it can have for those patients that we currently can't do anything for. As I said, I can talk about this subject for hours, and I realise that I'm quite close to finishing, so if anyone's got a couple of quick questions. Yeah. Yeah. Okay. So the EMAS trial tested 7 days, and after 7 days there was no effect. But actually we don't really know at which point that GTN stops working, because it's the nitric oxide that has the other potential benefits. So the neuroprotection, we don't know how long it takes those cells to recover. Okay, much like when you shock a patient in cardiac arrest and you then continue going straight on with CPR. If you are to restore a circulation, you have that period of myocardial stunning for those cells just to sort themselves out and restore their normal function. So it takes time after the initial intervention. My answer to the question is, we don't know how long nitric oxide works for. So we know it doesn't work for 7 days, so we're just going to shorten it to see actually how much benefit that does potentially have. And it might be that it's just really in the acute phase.
So after the toxic suspension,
yeah,
there still needs to be work within the brain.
Absolutely. Say that again.
So once they visit the coil,
yeah, yeah,
there still needs to be work done to help the stroke patients.
Yeah, absolutely, absolutely, yeah. So, and this is all, we're going to be working with the teams in the rehab for aftercare as well, just to see actually how this intervention might work. So it's really early days yet, but we just want to try and work out actually how effective that's going to be over that initial period, and what that initial period of effectiveness is. Okay, one more question. Yes, at the back.
What about the administration of aspirin?
Okay, yeah, oh, that's a good question. So for us, we don't know what type of stroke we are going to. If we're going to give aspirin to a hemorrhage, we might be in trouble. Now, without definitive diagnosis, Okay, we can't really begin any pre-hospital intervention. There has been trials into thrombolysis pre-hospitally. That's generally done by a doctor with CT scans present. Okay, but again, you have that element of risk. One of the other things that we're testing in this trial is biomarkers. So when a patient arrives at hospital, we're taking blood samples just to see if there are any proteins there that could help us to identify what type of stroke it is. Much like you get troponin in myocardial infarctions, actually there is some really new research that's trying to distinguish what proteins are evident when cells break down. You get your apoptosis, your programmed cell death, and when those cells start to break down, they'll throw off all different types of proteins. We're actually looking to see if there are different proteins that are thrown off between ischemic stroke and hemorrhagic stroke. And if we can tell a difference, if those biomarkers are more prominent in one or the other, only then can we start to perhaps develop pre-hospital stroke, more advanced pre-hospital stroke interventions. Primarily though, it is increasing the awareness of the urgency. If we can get those patients to definitive treatment earlier, then we can potentially salvage that ischemic penumbra and reduce the level of death and disability. Okay, brilliant. Thank you very much. All our contact details, my contact details are on the website. If you have any questions or later on this afternoon you wish to ask something that you hadn't, please do get in touch with us and we'll endeavour to help you.
Thank you very much.
Cheers.